Yeah.
Do you want them to, you want me to invite them to the next language barrier meeting, or
Sure, or they can
that?
connect directly to me. I want to also honor them as experts too in lived experience. And so if you feel like it's appropriate to directly connect them with me first, I'd love that to like support
Okay,
them.
well,
And
that might be good. Yeah, that
yeah,
they.
yeah. And also just to like orient them to
If
this.
you want me to be on that meeting with you, I can.
Oh yeah, how about you connect us and then since you're friends, we can take it from there.
Okay.
That would be great. Thank you, Rosie. I think we're ready. Again, thanks for your patience and everyone, thanks for your well wishes. I got that better. Welcome to the August 22nd Language Barriers and Incarceration Status public call. I'm really grateful for all of you to be here today. We have lots of subject matter experts on the call as well. And let's get into it. And so we can, and again, very clearly now, this is just language barriers and incarceration, our normal gravity terminology curation development process. We're moving the other program enhancements to the alternating week. Next slide. Welcome everyone. We do have a nice group today. We do mute folks upon entry, but you of course recognize that by now we are an open community. And so please, if anything's being said that is confusing or needs clarification, please raise your hand. You do not have to wait to the question period to ask your questions. The calls are recorded and always available on the Confluence for review after the call. And you know, our subject matter experts, not all of them can attend our SME meetings. So even some of our SMEs, one of them is going to be joining us midway today. He also is reviewing asynchronously. Everyone's always encouraged to actively participate in the chat, and I hope you can already see that I'm trying to monitor the chat to make sure that I don't miss anything. Whenever you're sending comments, please send them to everybody, and just note that anything in the chat has a likelihood of being read out loud, because as I'm trying to facilitate the group, I tend to just ensure that your voice is represented. Next slide. We have a requirement as an HL7 fire accelerator for following Gravity Project's antitrust practices. They have any participant in this space as a standards development space has the responsibility to comply fully with federal and state antitrust laws. That's just a common requirement of the space, and we just ask that everyone adhere to the guidelines. Next slide. There's a lot of Sarah here, but there's also a ton of subject matter experts on the call, and I'm going to be calling on folks to help walk us through some of these concepts. I tried to ping our SMEs and thinking about things in advance. We're going to be just refreshing ourselves first on the overview and the fall 2024 plan, which is a little bit different than usual. We'll then dive first into language barriers and language access. We have some new SMEs to welcome. Thank you so much to the CDC for asking for more SMEs, and thanks to our friend. Oh, sorry. Can you hear that?
Yes, there was an echo.
Yeah, I think it's over now. But I don't need to hear myself. That would make me a little... I'd fall down the stairs for a whole other reason if I had to live with myself all the time. So we're going to welcome some new subject matter experts to the group. So grateful again to the CDC for raising the idea, and for CMS for responding, and for our friends in the research ecosystem for rallying to the call. We'll then go through incarceration status. Per usual is our custom. So any new additions to our value sets are vetted here in the public group before they are included in value sets. So any terms we have discovered in our iterative process of ensuring we're on track, we show you all as part of all domain revisions. We'll review some of those. And then we have yet to be able to update you on our June 2024 value set update. Again, anybody who is accustomed to Gravity knows that we do lots of formal things, right? We try to have our processes be very transparent. So we have a June value set update and a December value set update, and Hamali will go into those details, and then we'll close. Next slide. Next slide. There's not a ton of announcements today. So just mostly just hoping that anyone recognizes that we do have our 3 work streams. This is terminology, where we are focused on language development and value set development, really creating the concepts needed to demonstrate the concerns and goals that affect our patients and clients and people's lives. Our technical work stream works on the exchange standard. That is every other week from Wednesday from 1 to 2 Eastern Standard Time. We're actually talking a lot about referrals over there right now. We're kind of thinking ahead into new use cases and new enhancements we'd have to do on the technical work stream and the implementation guide. So always fun to go there. And the implementation work stream is where we talk about how to implement the terms and data standards we create. August is canceled. We'll see you again on September 26th. Next slide. Any questions on the general roadmap or plan? With a quick little one. Okay, next slide. And for any new SME, welcome to the first public call. I always try just for the first meetings to do an overview for anyone who is well accustomed to Gravity. My apologies, but I just want to make sure everyone's aware of where you are and what we do. Gravity Project is a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. Oh, I think we're going the wrong. There we go. Might be going the wrong way. There we go. Perfect. Okay, these are our members. We cannot do what we do without our members. Unique to us in the HL7 ecosystem is that we have designated members. In addition to our members who help sponsor the work, we have members who we feel are critical voices in the work from a social justice framework, including patient advocates, CBO advocates, entities that normally wouldn't be able to, be part of the normal HL7 sponsorship model. We designate them as being important and include them. And we couldn't do anything without any of our members. So thank you so much to all of you, including our in-kind friends who help make the work go forward. Next slide. This is the timeline, Gravity's very busy timeline. I still don't know how 2021 happened. It was amazing. It was a moment in time. But we've, again, found, conceptualized in 2017, kicked off in 2019, have now addressed 20 plus domains and are currently working on incarceration status and language barriers. And we've had a couple different iterations of our implementation guide that, again, develops the exchange standards to encompass exchanges between clinical settings and social care settings, given that clinical and social care collaboration is critical for addressing social determinants of health. Next slide. This is our roadmap. Here we are. We're still working on program classification enhancements and coding for food. That's all going to be happening again in the alternate meeting where and then in terminology, we're going to be focusing on language barriers and incarceration status here. Still, again, as I mentioned, conceptualizing new use cases for our tech standards, and that's happening in those Wednesday meetings, and the implementation affinity group carries on. Again, our work in tech is focusing on aligning our IG with Core 6.1. That's the big push this fall. Next slide. As a social justice organization and collective, we do have principles that guide our work. I say often we address the primary injustice of data injustice of invisibility in our work, which is designing terminologies and standards to make critical concerns visible that are not often visible. But we also recognize the injustice of being visible and possibility of bias. So we have our 6 principles that we co-crafted in 2019, improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and ever so importantly, preventing, reducing, and remediating harm. I want us to think very critically of these as we think about the access elements and incarceration status elements. Like our domains today are very clearly domains that are about equitably accessing resources, but also present you the concern of bias as you intersect with different settings. So these principles are very critical to all our domains, but of course to the 2 domains we're addressing this fall. Next slide. I think we're ready to do some content. Anything else? Any questions? Thanks for humoring us as we do one more Gravity overview before we can sunset that in the next meeting. All right, and for those of you who have never been to a Gravity meeting, welcome to the Gravity overview. All right, next slide. All right, so this is where we are. We are in the terminology identification phase of our terminology curation process, coming up with the concepts that we need to define in encoded terminology. Next slide. We want to honor the fact that the work that we're doing here is supported by a partnership with Regenstrief and our friends at Regenstrief Our task as we work with Rich and Strafe are addressing prioritized new domains, and that's us here, and also ensuring completion of prior domain terminology submissions. So thank you to our partnership for Rich and Strafe, which is really underwriting a stable pace over the course of the next until 2027. Next slide. All right, so this is the process that we embark in whenever we come to this public call. And this is partly, again, why we carved out program enhancements to another meeting. This is the process you all helped shape and create. So it's evidence-based, again, grounded in the expertise of subject matter experts and the literature, consensus-driven. Here we are. We're always trying to center community perspectives and ensuring pragmatism in this open process. We always try to ensure that we're naming things in ways in clinical spaces that align with the ways things are named in other spaces. And we have lots of colleagues from the federal ecosystem in our SME group to assist. Experts who can ensure that we are aligning our terminology with the way the DOJ or Bureau, Department of Justice, or the Bureau of Prisons talks about concepts, because we don't want to misalign. And then, as always, we're principled. So we'll spend a fair bit of time just coming up with ideas. And at the end of our process, we go through a kind of formal end-to-end review. And then there's a consensus vote at the end of the fall, right before Thanksgiving. And then the Gravity team then goes behind the scenes and builds every single gap concept we can into code. Hi, Rata. All right, now next slide. And this is an example of what comes out of that process. So encoded screening instruments, encoded diagnoses, encoded goal statements, and encoded interventions, including all of the critical interventions for the 2 domains of reference. Next slide. And then the value sets, so we curate all of that information. Again, Hamala is going to be giving updates on our prior value sets at the end of the call. Next slide. Okay, so I already mentioned this. This is language barriers and incarceration. Next week is coding for food and program classification, and we'll be alternating every week in order to get the work done. Next slide. And this is this meeting schedule, and next slide. And then there's the next meeting schedule. You'll see that both of them convene on November 21st for that consensus vote. Again, our goal is to ensure that we roughly maintain our process, because our voting is aligned with when we need to work to get coding submissions into standard orgs. So the 11/21 deadline aligns with the submission deadline for the next IC10 coordination and maintenance committee meeting by design. Next slide. All right, and you can find the masters. And again, probably the biggest up-to-date master will come after the next meeting. Again, we always update masters onto the Confluence the Friday after a public call. There's not a ton there right now, but there's we're going to be talking about concepts today, the concepts that matter for our 2 domains, and that concept agreement drives the instrument selection. And by the end of the day tomorrow, we should have a fair set of instruments that are ready for all of your review, and a sandbox of incoming concepts. We'll talk more about that in a second. Next slide. Okay, any questions on that specific terminology process? And now we're going to get into language access concepts and then incarceration status concepts. Okay. Next slide. All right. And we start at Gravity whenever we do a domain with we throw things out there and then we hash them around. One of the things that we're determining right now, and Darcy is one of our subject matter experts, and we have Julio on the call, and we have we have Gerardo on the call. We have a few other SMEs from that group. I'm trying to make sure that I did not miss anyone. Is what we call the domain, right? In our last SME meeting, is it language barriers? Is it language access? That is to be determined, and will be guided by our subject matter experts as we go forward. Next slide. We have 2 new additions to our subject matter experts. Super excited to have them. So when we were last here, we introduced Alfonso, Gerardo, and Julio, our 3 CDC, immigration, health, and language access experts. I know Gerardo and Julio are on the call. I think Alfonso might be out of office. We are really honored to welcome from CMS, Darcy Graves, who's Technical Advisor for Center for Medicaid and Medicaid Services. She can wave to you from her nice office with all of her great books that I wanted to read. And she's an expert in some of the class standards that we were discussing at our last meeting, and is a really critical voice that we're very, very grateful to have as part of our subject matter work. And then, Darcy, anything else you want to say? No, just hello.
No, just hello and great to be here and look forward to working with all of you.
Fantastic. Marcia is not able to be here right now. So Marcia Registine is a professor at the Milken Institute of Public Health at GW. She's an expert in actual system-wide implementation of language access policies and standards. So we have a little bit more of the the central federal government approach and federal approach and standard-based approach. And then we also add a little bit more of the system-wide policy and implementation approach by adding Darcy and Marcia, and there might even be a few more SMEs coming down. But this is our current language barriers and access subject matter experts, along with our wonderful friends, Alfonso, Gerardo, and Julio, who were here prior. Thank you so much, all of you, for assisting. Next slide. And welcome. So this is a grounding again. We're going to get into concepts in the next slide. And again, Gerardo, thank you for kicking all of this off. It's really due to you, right? So the need for addressing language barriers grew out of prior work with health literacy. We just want to note that as an access-related concept, as with health literacy and equitable provision of care, a given community system or setting effectively meets the language and communication needs of any individual, right? So what we will be identifying are statuses, and we call them statuses that put individuals at risk. And in an equitable society, no status would put any individual at risk, right? In an ideal state, I'm always thinking about the artisan, right? And then, but what we are aware of is inequity occurs and risk arise when the system or setting does not. So what we talked about last time was delayed care, lack of preventive services, poor quality care, increased utilization, all kinds of concerns associated with language mediated access concerns. So as you know, Gerardo, you were, oh, hi, Lucy, yes. Do you have a question? You're muted if I can't hear you.
I'm talking. Can you hear me now?
Yes, hello. Yeah.
I have to listen to you on the phone, so I'm sorry.
No, that's okay.
Language and communication needs.
Yep.
What does communication refer to?
Oh,
Thank you.
Darcy, do you want to take this one?
Certainly. So that is one of the first things that we are diving into, is to think through all of the different ways that both language and communication can have that status impact. So communication, for better or for worse, there tends to be a bifurcation when we talk about foreign language, which is usually referred to in that language access standpoint. Whereas if we're talking about someone who is deaf or hard of hearing, who is blind and have low vision, they tend to be, again, for better or for worse, it tends to be more discussed more in terms of communication accessibility or communication barriers. And so one of the first things that we are trying to do as a group, because and this is only my second meeting, so I could be making things up and Sarah will clean up after me, but is to determine what are appropriate guardrails for us to think about in terms of language barriers versus communication barriers versus needs for other kind of communication tools where a device, a letterboard, or those sorts of things. So it can very quickly you never want to boil the ocean, especially when you're trying to come up with concrete terminology, but we also want to make sure that we don't exclude anyone, because American Sign Language is by definition a language. And so and Milan, that is exactly what we're trying to the augmentative and alternative communication things is part of those discussions, and I'll let Sarah speak to any additional SMEs that the group might be looking for. But that's how that's part of the, I don't want to say struggle, but that's part of the discussion and things that we need to determine to make sure that we are being as inclusive as possible, but while also making sure that we are concise enough to make the project a success. Sarah?
That's great. Thank you. I was anticipating that that's what you would say, and I'm already leaping to resource issues are really different, at least in my mind, for language and communication. So maybe we have to keep that in mind throughout our discussion. Thank you.
Absolutely. The resources are very different, and the way the law treats these pieces are very different. And I know that, you know, that's not necessarily implicated here, but I think in terms of how things get operationalized or how we think about things and the recommendations we make in terms of terminology, we'll need to have that informed lens as well, because communication is much more set in law and statute, whereas language access is a bit more, to use the super technical term, squishy, and is much more reactive. And so that's also just one of those things that we have to try to grapple with as we move through the issues raised when we talk about language or communication.
Thank you.
Or communication barriers.
Glad you're here.
Absolutely.
Thanks so much.
And thank you, Darcy. You're so great. Good job. And Milan, and just to answer your question, we've broadened the bench. Does that mean that Darcy would say she's comfortable representing communication access? No, probably not. Like, I'm just gonna, Darcy, I don't think you would say that about yourself, right? Yeah, no, yeah. So what we're trying to do is broaden the bench enough to make sure that we're identifying things equitably and with sufficient risk. And so, Milan, we're still looking for specific expertise in augmentative and adaptive alternative communication. And Darcy has resources. Darcy's helping me reach out to many of the people that I tried to reach out to before. So thank you, Darcy. But I would say we're still trying to exploring it. And I feel like what we're exploring is actually kind of going to unfold on the next slides. We can't neglect to acknowledge how communication access influences language access, right? And so but we don't, it might be its own domain, right? So we're kind of in that little realm right now where we're trying to feel it out. But this is what we always do in the second meeting of any new domain. We always kind of occupy these gray zones. Next slide is kind of appropriate. So things that we have, because what we are doing now with all of you, and because this assists us in assessing things like screening instruments, is try to ground ourselves in the base concepts of the domain, right? So what do we know, right? What do we know is within scope and what might not be within scope? And you can see the same scoping elements carrying over into the incarceration status domain. What we know that we have so far on the table is concepts in primary language, concepts in English language proficiency, concepts in preferred language, concepts in needing interpretation, and concepts in needing translation, right? So those things are kind of like solidly scoped, right? And I say solidly, I mean like we're fairly comfortable with them, right? And just as with health literacy, and Julio, Gerardo, feel free to come off. We also are just trying to make sure that we clearly recognize with, as we did with health literacy, both person level and organizational level responsibility, right? When we did health literacy, we were very, very clear to say there's personal health literacy and there's organizational health literacy, right? Organizational health literacy being the capacity for that organization to support the person at where they are, regardless of where they are, right? And person health literacy being that individual measurement. The same thing applies here. And this partly with our increased SME bench, some of those organizational elements we're delving into, but this is kind of where we stand right now, right? Is these are the primary concepts that we're looking into as we think about the things we might need to name or define. And these are the primary concepts that instruments would be screening for. Anything else to say, Darcy, Julio, Gerardo? Are we good?
I do have a comment,
Yeah, bring it.
if I may. I would consider language access or language barrier a type of communication barrier as well.
Mhm.
Are we under the same assumption?
It depends on how, well, we are shaping that assumption together. I would say. So what you're saying is you imagine language access as a type of communication access?
Yes, because when there are two languages, there is no effective communication.
Mhm.
And so in that regard, I would consider language barrier a communication barrier. Is a quintessential, language barrier is a communication barrier, but not every communication barrier is a language barrier.
Great. That sounds great. That makes a lot of sense to me, right? So, but I don't know if that, I think we're shaping that together, right? So language would be one type of communication access concern. Lack of appropriate devices to communicate in a language would be a second communication access concern. Is that what I hear you say? I mean, roughly.
Yeah, yes. And not to throw another layer of
Do
complexity,
it. Yes.
just like you identified American Sign Language as a whole separate language, there are versions of Spanish
Correct.
Sign Language as well,
Yes.
which
Yes.
Oh,
which
absolutely.
which I have yet to see data in the US.
Mhm. Yes, and we also know there's like Indian Sign Language, there's multiple different like subtypes, and there's British Sign Language, right? So there's multiple different subtypes. Okay, so maybe, okay, so thank you for, here we are scoping on the call. Classic us. But that's helpful, Gerardo, thank you. And I see some agreement there. Any other questions or concerns on this initial scoping? All right, so now we're gonna go on to the next slide. Oh, hi, Julio, please, hi.
Just since we're scoping a little bit, one of the things, and thank you, Gerardo. I was caught up in something else, and I couldn't talk about language, communication, and the intersection of those two things. Because, but just to unpack that one little bit more, there's the practice of language, and then there's the mechanisms of communication, right? And in the context of even outside of disability, there's the mechanisms of communication in multiple languages that may not exist either organizationally or structurally, that even if you don't have a quote unquote disability, you may not have the means to get any oral or written language communicated to you or with you, right? So the mechanisms may not be there. So I'm also thinking about that intersection from a structural standpoint as to what the built environment is, right? So that aside, one thing that we've just started having conversations about in the agency around this issue of communication and people with disabilities is cognitive disabilities, and the perception of cognitive disabilities, particularly in that last sub-bullet under the first bullet in your slide on primary language of thought, in that language can also be interpreted as a manifestation of a cognitive disability. Certain cultural expressions being identified as an indication of psychosis or disassociated affect or trauma or whatnot. So I'm wondering at what point will this issue of I'm not sure if I have the words, but the issue of intellectual ability will be taken into account in the context of language barriers. Over.
I think Thank you so much. I think that so tomorrow when we huddle, let's try to map out communication in the umbrella that we've been discussing here, because I feel like there's space to address that concept there, right? I think we can, it might not be in a spreadsheet. I might need to get out my like whiteboard. But there's always room to address things that matter, and really grateful that you can help us do that. Does that sound good, Julio?
Yes, thank you.
Awesome. Okay. Any other yay, Darcy's clapping. Any other things that need to be this is initial scoping again. It's already been like refined and tossed around in this call, but grateful for all of you. And again, all those notes coming soon to a SME meeting near you. So we meet right after this tomorrow afternoon, and we'll make sure that we continue scoping. And again, next meeting, you'll see some of the instruments that we have that attempt to drive at some of these concepts. And Darcy, I just want to honor you for the fact that even concepts of written language are language based. Like some languages don't have a written language. And so we have to make sure that we're thinking with like cultural perceptiveness, and when we do this work as well. Okay, next, any other thoughts? Next slide. So are we in scope where risk refers to right to? Oh, Denise, help me understand what you mean here. Decrease.
Yeah, I'm hung up on the risk part. I'm sorry. Especially
Okay.
when you experts went into the language of communication. So we're trying to define this by scope. And are we just dealing with social risk? Because as I typed, I'm in a clinical area and we're trying not to use risk-based messaging, which has nothing to do with what we're trying to do here. But I'm trying to follow the thread of the scope here and thinking that we're just talking about social risk. I'm making it.
So the greater bucket is kind of why we were using the word access in some of our newer language. Like anytime there is a status where there's a disconnect between services that can be offered and where people can be met and where the person is, it has a potential to threaten access to resources equitably, right? And
Right.
that is one of those things where we say it's not a risk that the person has inherently. The risk is in the system, right? It's not, I don't carry that risk myself. It's not like food insecurity, even though it's like the risk is like, yeah, I am at risk because of the bias and lack of
Yes.
resource of the system.
Oh, got it.
Does that make
Thank
sense?
you.
Yeah, it's not my risk. Like I'm fine.
Yeah.
Right? I should be able to be just me. And the
You are
system.
so good, Sarah. I got it now.
Okay.
Well, all of you are good because I was dealing with this and now I'm like, oh, okay, the environment, the system. I got it. I got it.
Yes,
I had the same questions.
Okay.
Did you really?
I was like, explain to me, I was like, are we calling this an SDOH? What are we calling this? And then Sarah did her exact explanation that she just did. And I was like, aha, okay.
I had to bring up the World Health Organization framework for conceptual action on the social determinants of health with Darcy. I'll bring that. I forgot. Darcy,
Okay.
I was going to bring it up because there's this whole, it's my favorite model. I'm sorry. Yeah,
I have to use it.
I have a favorite model, right? And there is that level of social and structural risk, which is just the person intersecting with the unjust system, right? And those are the statuses we're talking about in the realm of like race, ethnicity, gender, sexuality, like language, right? All of these different things, right? It's not the risk I carry myself.
Got it. Yeah. Okay, all of you. I appreciate you all letting me step out of my little.
No, love it. And I'm going to bring that model back. If I have a favorite model, I should be able to show it around every once in a while.
Okay, I'm back on track.
Okay, Julio.
I would encourage you to have that reference resource available for people. We do use that conceptualization, for example, when we're talking about vital information during an emergency response, right? In that it's not that the person is involved in risk taking, but that the context of risk may be unknown and subject to, for example, the information that's available in the language that they don't speak, right? So are they able to take action? So I really like your principles in the earlier slide, which talks about the individual's ability to, effect authority, personal autonomy and authority, right? So that's the way that we're also talking about risk. And that's why I was asking about disability and language in the context of either not diagnosing or misdiagnosing a person, right? Because they might be incarcerated or institutionalized based on that. Here's the question, though, which we're going to have to get back to at some other point. And I get you already spoke to that we'll do that hopefully starting next week. But there are some areas where the person might be at unknown risk for themselves, right? Which might be embedded in the information that we're trying to get to them. That's not available in a language that they understand. We haven't accounted for that. We haven't accounted for people like we typically approach this from the prevention mode, right? Before risk has been engaged. The risk of lack of language accessibility is what we're trying to mitigate. But it might be with a population that is engaged in a context of risk. And so I'd like for us to stay in the lane of the risk that we're mitigating rather than the risk that they're engaged in. Does that make sense?
I'm with you. I think
Okay.
I have the model in my head. We can map that out tomorrow along with it.
Yeah.
Let's do it. Okay, wonderful. I'm glad that this approach aligns generally, but it's really important that the whole reason of putting scoping statements out is that we can see gaps, right? So we know what we know some things that we're pretty solid on. We know some things that we're not, right? Then thank you, Julio. We are almost, so one of the things we wanted to note, and this goes back to what we were talking about before with communication access, and maybe communication access is the top one, and language and devices are side by side. We'll do all that visualization and come back with you. Lucy, maybe I'll even make it sound like a word cloud. Lucy loves a word cloud. So I just want to note that we, again, still are reaching out to communication access subject matter experts. I'm talking to all of my SLP friends all the time. One of the things we were talking about on the language access SME meeting is there's different places I refer to if I have a problem based on these two things. If I have a problem with communication access, like devices, again, Gerardo, I'm hearing you that it might be different. I refer to speech language pathology, right? Versus referring for interpretation. One thing we want to note that already exists because of the critical nature of this is there is terminology in the ecosystem to document use of augmentative and alternative communication in patient records. So that's one thing we know we have. And so one of the things that we're like, as we figure out scope with communication and language, we just want to know there is a fair bit of terminology regarding this concept. And of course, there's all of the referrals to SLP and lots of device terminology, but just note that that's already here, which is reassuring. Next slide. And then just, again, still working on it. So Milan, we've broadened the bench. We haven't completed the bench. We're still working on it, right? Some of Rosie's friends are going to help us from a lived experience perspective in using devices for communication. Really grateful for having that come into the work as well. And we will keep on scoping and come back shortly. Any other final thoughts? Thank you, Sarah B. Sent any ideas? And again, we're reaching out directly to ACL and have in the past. And Darcy, thank you for that. Again, we just want to make sure that we're operating from an equity-based perspective and ensuring we're including everything and evaluating everything appropriately. Language access to me is any final thoughts before we move on to incarceration status? We doing good? Okay, more to come. Next time, friends, we'll start seeing some of the instruments, of which I apparently have a favorite. The National Latino and Asian American Survey. Who knew that I had a favorite language access survey, but I do. Next slide.
If you have a favorite framework, I have no doubt that you have many favorites.
I have many favorite things. Yes, nerds and there are many favorite things.
Yes, no. It's all good.
Yeah.
I'm just saying.
Yeah.
You don't
Yes,
have to apologize for
I
it.
know.
Just
Just
own
know
it
that-
and embrace it.
I know. I just know that Darcy, this is her first public call and she's tracked me instantaneously in one meeting. So Darcy, well done. All right, so now moving on to incarceration status, and thanks, friends. This is a two. I will definitely send the framework around I have the World Health Organization framework, if that's the one that you mean. It was like the founding framework for my dissertation. We'll bring that around next time. And if you mean if that's okay, great. That's the thumbs up. Okay, so now we're going to move into incarceration status. Next slide, and we're going to start talking about scoping there too. I just decided to bring back some of the slides. So we have Rada, Milan on the call, Sandra's on the call, Tyler's on the call, Eileen was on the call, Eddie, thought I saw you too, right? So we have a fair, if I'm missing anyone, my apologies. I think that's most of you. Again, thank you to all of our.
We're still here.
Yay, Eileen, hi. Thank you to all. Oh, Andrea, also, I think actually I saw you too. Andrea Finley, at least I thought I saw you on the call. Yes, I did. Hello. Okay. So thank you to all of our subject matter experts in incarceration status. This is a very complex domain. If we thought language access was complex, I'm learning so much as I go along with all of you. I'm really grateful for all of you. Next slide. And Tyler, thanks for being on camera and agreeing to be point on some things. Hello, Tyler, welcome in. All right, so again, this is actually very similar, Denise, to what we were talking about prior. So incarceration status, again, is one of those domains that puts individuals at risk of both health and social adverse outcomes. In an ideal society, that wouldn't be the case. The risk arises from the intersection of personal histories and structural barriers and biases. This is what we talked about last time. So higher rates of mental health concerns, chronic conditions, substance use disorders, barriers to access, and financial insecurities. And then we wanted to note again, because you're going to see this play out in some of our dimensions, incarceration is a health and social risk to the individuals, but also their children, families, and social networks. And so we're going to be, as we scope out, we're thinking about all of these things. Lucy, yes, hi.
As we know, in California, incarcerated individuals have higher rates of sexual abuse, being subject to sexual abuse. So do we want to add that? Or is that a different realm?
No,
a different domain?
no, anything that this is the why. Why are we leaning into this domain? Why does it matter? This slide. And so if we're missing something, we can absolutely add it. Thank you. Julio?
Can we broaden abuse to just violence?
Yeah. Absolutely. I have to find a citation anyway to put it on the slide, so I will do all this things. Yes.
Yeah.
Sarah,
Yes.
I'm sorry. I think sexual abuse deserves its own bullet. And if we want to consider violence in general, that may or may not be sexual, that's maybe 30 minutes to talk about. I have no objection to more violence, but I think that sexual abuse has such particular potential danger to people who are incarcerated that, to me, it merits its own bucket, if you will.
So Lucy, what I'm going to do is I'm going to take that thought, take it to the SME meeting tomorrow, make sure it gets represented adequately according to all of the lit, and then come back.
Great.
Thank
you.
Anything else? Okay, fantastic. Again, not fantastic. It was a very horrible conference. I'm glad we're okay on this slide. Next slide. I'm going to move through the background slides because I want to start talking about concepts. We talked about the financially driven insecurities last time: food insecurity, housing instability, homelessness. Next slide. And these are tables pulled from prisonpolicy.org on those entities. So twice as likely to experience food insecurity and significantly higher rates in homelessness. And again, our SMEs really wanted to make sure that we talked not just about homelessness, but also about housing instability. And there's plenty of bias in there as well, right? So when we think about difficulty securing a lease on an apartment because of X, right? So just want to note that thank you, our SMEs, for making sure that even though it's not on this slide, housing instability was part of there as well. Next slide. And then this is a slide I made before, like after I sent the slides out, because this is a really complex domain, right? And so what we see ourselves talking about over the course of these next months are primary concepts and secondary concepts, right? And and Tyler's like leaning in, right? So you'll see over the next slides incarceration and its subtypes, of which I did not know anything about until the SMEs gave me an education. We're going to get on there, right? Community supervision and the subtypes therein. Other concepts that have been raised by the subject matter experts as being critical are the assessments of risk, like risk of recidivism, and risk assessment to drive supported plans. So there's all kinds of different standard instruments that assess risk, right? And those are instruments that our SMEs have sent us as well. So we have instruments that screen for primary concepts, instruments that screen for secondary concepts. Including in secondary concepts are those loved ones who are incarcerated, again, social network, family member, parent, primary caregiver. So these are all the concepts that we're hashing out as we go forward. And on the next slides, we'll go into them deeper, and I'm going to ask our SMEs to help take all of us along with the education that I got to have on Friday and the terminology team got to have, because again, much of this was opaque to me prior. Next slide. So one of the things that we are talking about, and again, Tyler, Rada, Milan, Eileen, anybody, please help us here. So one of the things that we were talking about is, prior to this work, I had no idea of the different subtypes of different types of incarceration. I didn't know there was a difference between jail and prison. I didn't know any of those things. So if our SMEs can help us walk through some of these concepts, that would be really great. And again, not too long, because we're just doing an early scoping, but that would be really helpful. Tyler, do you want to take a go? Milan?
Yeah, I can kick us off, but certainly there's plenty of expertise on the call, so I'm sure I'll miss something or mess something up. So a couple things. One, this is making me realize that there's two distinct concepts that haven't been clear in my mind till you were just talking for some reason, Sarah, which is currently incarcerated versus recently incarcerated, and that's clinically relevant. And so sort of within those two concepts, there's jail. Jail refers to sentences less than a year. And when you're in jail, you can either be pretrial or you can have been sentenced typically to a sentence of less than a year. And those can either occur in the same jail, or in some counties that those occur in separate jails. So like in Hennepin County in Minneapolis, where I am, we have two jails, one that's anyone who's pretrial, and then one for anyone that is post-sentencing. And then there's prison, which is can be state or federal, and those are typically longer sentences and determined based on the conviction and the type of crime. And then, yeah, juvenile detention centers are also like can be somewhat heterogeneous in that they can look very different across jurisdictions. But typically, folks who are not adults yet, somewhere in the 12 to 17 range.
Fantastic.
Is that helpful?
That's very helpful. I didn't know any of that before last Friday. So Milan, Sandra, Eileen, Eddie, anything else to say on those concepts? You helped us all get there, right? So these are all statuses and concepts that are critical because they represent different stages and severities, of course, like essentially.
Yeah, I think the only status missing was community corrections.
Oh yeah, so that's
Halfway houses, things like that we need to add that status.
Yeah, that's on the next slide.
Oh, okay, sorry.
No, that's totally fine. Yeah, so I tried to, because this was so complex, I wanted to make sure that we had these different types of being incarcerated as well, right? Okay, fantastic, right? And again, perfect, right? Okay, great, yeah. I see the good tap.
Sorry, this is Sandy Springer. The only, and just to make it even more complicated, you have certain states where they're unified. So you have systems where they're kind of jails and prisons, like in Connecticut. It's a whole unified system, so they're not distinctively. So for instance, our one women's facility is jails and prisons together. So then when, you can see where that can go, right? So in terms of types of offenses as well, all the way. So yeah, it gets more complicated.
But suffice to say, the status is sufficient to represent the risk to the human, right, or the risk to the person. Right. Well, we can scope all of that out, right? And now, one of my first meetings with Sandra, we were talking. Sorry to call you Sandy, just Sandra. We were talking about the capacity for these terms to, if they're in their consistency, to be so beneficial for things like state policy and research and outcomes evaluation, right?
Yeah,
so
absolutely.
Yeah.
And then we'll get the fun part about talking about kids that are serving time in adult prisons or jails and have all sorts of extra requirements as well.
Yeah. And that
Fun.
actually might be like a specific, just holding space for our meeting tomorrow. That might be a specific extra special risk factor that we want to represent in a specific concept, right? Juvenile serving in adult detention center or something to that effect. I mean, again, not an expert, but just like holding space for those kinds of things that if they're super critical, we can represent them as well. In addition, just again,
Sarah,
go for it.
Sorry to not to go on a tangent, but that is actually it sounds actually like a very niche thing, but it's actually very timely and policy relevant because CMS has new policy that will extend Medicaid to youth and young adults, sort of regardless of what facility they're in, beginning in January.
Fantastic way to have this, fantastic, right? And so again, identifying that seems like a really helpful and critical thing to do. Okay, so I'm putting a pin in that one for tomorrow. We have communication access pin. We have all kinds of pins for tomorrow. I'm gonna ask my SMEs to help me hold accountable to that. In addition, again, from a point of thoroughness, we just raised the concept of military prison, not wanting to exclude it. Just trying to figure out where that might set, and then noting, as a kid, anyone who was on the utility and security work knows that whenever we say there's a state anything or a federal anything, we need to ensure there's also a tribal equivalent, right? From an equitable, autonomous jurisdiction perspective. Oh, Darcy, hi.
I would also argue, again, depending, like, I don't want to do scope creep, but also keep in mind the U.S. territories.
Exactly. We did
I know.
That was our utility and security gut check, right? It was state, federal, territorial, tribal, right? Yes. Yeah.
Okay.
And Darcy's a specialist in all kinds of things, which is why she raised her. Jonathan?
So I just had a question, right? Because I'm a layman to a lot of these things. So is this a way to like create an umbrella and then have like rabbit holes or different pathways that you can go down as you start to develop more scope into what the terminology actually means?
I'm
So-
trying to, I think it's more like a parent concept of incarceration and different subtypes, which are all statuses of incarceration.
Okay, so then having an overarching concept of what incarceration is, and then being able to drill down on specificity after the fact.
Correct.
Okay, thank you. I just wanted to
Or
make sure.
during the fact. Yeah, because before last Friday, I wouldn't have recognized that those were different subtypes. Right? And so,
Well,
but they're critical.
hopefully you haven't spent any time in the correction system, right? So you wouldn't know those things. You haven't worked in that, so you wouldn't know. But sometimes I just get concerned that we try to over engineer it up front and then we try to forget things afterwards, right? So having more broad generalizations and then being able to get very specific and nuanced after that, I think would be a more reasonable approach, but I could be wrong.
No, you're Tyler and I were just talking about this as well. What's missing on this table is that for like the jail pretrial and jail adjudicated concepts, there will also just be a simple jail concept, right? And you can drill down to further specificity because that's the way we have to build terminology. And above, so it goes incarceration, jail, and prison, right? And you can drill down. More to come, Jonathan. I promise you.
No, I'm just here to ask the naive questions. That's it. So I want to
No,
ask.
not naive. Yeah.
I
No.
asked naive questions, so thank you.
Yeah, no, that's not naive. Tyler and I were just talking about that today at 1:30. Like, and what's missing on this is the simple, and on a different version of this, there's bullets that has on our sandbox that we use with the SMEs, there's a jail concept, and then under it, there's two different subtypes, right? And so you can drill down to the level of specificity that's required.
Thank
Julio.
you.
Oh, and I have, Julio, this is for you here, this last bullet. Just want to note that we're hoping to have a special session. If we have CDC immigration health experts in one domain, and we have incarceration status experts in another domain, we want to meet in the middle to make sure we adequately represent immigration detention centers. It gets its own call out here. It's not even on the table. It has a whole box, right? So Milan, Rada, we were all, I just want to like, this is the box we made for you.
So that was one reason why I raised my hand, because I was wondering how the carve out, as opposed to, like, so for example, there's ICE detention centers, but then there's also regular incarceration where people might be there but not in ICE, right? They're not there because they were found to be immigrant. They may simply not be a citizen and been in a jail cell. So I was wondering, how does that as a incarceration status get identified? Then the other question I had was what seems to be sort of the elephant in the room with incarceration is health status while incarcerated, like, for example, pregnancy or terminal disease. Like, we used to have a HIV and incarceration program, but it was too difficult to stand up because of the barriers of trying to address health care needs within the institution while they were incarcerated, right? So where does that fit under these categories?
4 of our SMEs are practicing physicians, so I'm going to ask Tyler, Milan, Rada, Sandra to pipe in there. They're physician researchers, so I'm hoping they can help us.
And just to make sure I understand, the question is sort of how to identify health status during incarceration.
Yeah, for example, if the person finds themselves pregnant during their tenure there, right? Or they're diagnosed with a disease after having been incarcerated, right? So what does that change the status of their institutionalization?
I guess what my initial thoughts are that you would identify, I mean, there'd be my initial thoughts are that you would sort of add multiple, like thinking about writing a note in a jail, you would add multiple codes. So you might have like hypertension and um, then an incarceration code. And then you would be able to pick up sort of a condition that first appeared in someone's record during a period of incarceration, or you could identify if someone after incarceration had like DKA or uncontrolled diabetes, and they had that was the first time diabetes showed up in their chart, and then you would add like a recently incarcerated code is potentially sort of how this could be operationalized. Those are my first thoughts.
That makes sense. Julio, was that helpful?
It
It's a
is.
little
I'm
bit
just trying to
what-
get us, I just want to make sure that we do have a thought about that as we
Okay.
move forward.
Great. And again,
Yeah, it's sort of how we look at conditions during pregnancy, actually.
great. Andrea, hi.
Hi. I know I'm in the SME group, so this might be for tomorrow, but and I'm new to this, so I don't know where this is going yet. So these are things that people would record in the health records. I'm wondering specifically about juvenile detention, but also I think this is true of military prison. In a lot of cases, those records are sealed. So we would be asking someone to tell a healthcare provider about something that would then reveal to other healthcare providers something that is sealed. This has come up in the VA, so.
Yeah, no, Andrea, that goes, that whole, not only risk of, like possibility of being made visible. That's a really good question for tomorrow. It's like how much about consent and privacy and legality are we even able, we might be able to say history of, right?
I don't think so with juvenile, because this came up. Yeah, I don't think you're supposed to. That shouldn't be somewhere else. If it's totally sealed, then you'd be unsealing it. But anyway, we can talk about that more tomorrow. But I think I actually don't know I know very little about military, even though I'm in the VA, because it's a completely separate system. But I also think a lot of those records are sealed. So I'll try and get more information on that. But anyway, I just wanted to bring that up. And I wonder if that issue is also something with immigration, because people can be determined to be legally in the country, but then there could be a record somewhere else of, where people misinterpret information. So I think, yeah, we have to be really careful about that.
Yeah, yes. And so I wonder, we have family medicine folk, right, on the call. And so maybe we can, on our SME groups, maybe we can tackle some of that tomorrow and make sure that we're staying in alignment. Sound good? Okay. I hope that, yeah. Okay.
I guess I would just add, from my very great distance from all of this, is that social concern about people incarcerated, whether jail or prison, has risen a lot in the last few years. And so the idea of records being sealed, I didn't know. And I would like to connect that with the rising level of concern from the outside, and whether from the outside can be allowed to look in and address, whether the outside can be informed before release so that something is waiting. I'm struggling how to express this, but I know that people want to, quote, be helpful, unquote, and let's not talk about what that means, but people want to be helpful both inside and upon release. And maybe you and the experts in your own meetings could talk about if records are sealed, what happens then?
Yeah, so that part of the context, Lucy, are the multitude of reentry waivers and that are designed just this and like navigating entities from currently incarcerated states into the community successfully, right?
Right, yeah, exactly.
We luckily we have 3 DOJ experts in our SME group, right? So I was just like nodding to the physician researchers, but I want to note that maybe, Andrea, we can look to our DOJ friends for some of the clarity there on privacy and consent. Eileen and Eddie, sorry to throw you under the bus, or Mariel, but we do have a pretty robust group of SMEs, and then we even might have a friend coming in from Bureau of Prisons as well. So I think we have a good group of people to help answer that question, and look forward to coming back next meeting. Julio?
Just to make sure that it's registered, when I was bringing up the issue of the medical issue, it was granted there's this issue of sealed records. The issue we were finding that was of a significant challenge was of facilitating or ensuring any health services while incarcerated. And so it's less about whether there are records that are sealed that identify a protected biographical information, and more about equity around
Care.
healthcare access while incarcerated. That was difficult to negotiate, facilitate, or even identify because people were not getting tested or examined, right? So I'm wondering about all of that.
Well, not to throw you out into the public here, but I know that one of the things that you were talking about in the first call was hoping to have some of the data possibilities of things like this and things like reentry waivers break down some of the barriers and coverage, federally for people who are currently incarcerated. You were mentioning the federal legislation and insurance coverage, I believe, in our first meeting. But just want to I want to note that our SMEs bring that to the light often, the gap in actual care provision. Milan, sorry to pull you out of there, but I know that you mentioned that as part of your reasons why, right? I don't know if you're, I think you're still on the, oh, yay.
Yeah, yes, I'm still here. Yeah, thanks for noting that.
Wonderful. Okay, so now we're going to go on to the, are we good with this slide? So we're going to go into some of the community statuses that we had on the next slide. Next slide. And so incomplete here are the other scoping concepts that we had. And there was some, I saw work release, someone was putting that in the chat, and we might need to examine that. But we have, so our primary concepts are concepts of the incarcerated concepts, and then we also are exploring the community supervision concepts and the statuses therein. And then the other 2 concepts that we are holding again, so we have incarcerated and all of its subtypes, community supervision and all of its subtypes. And then the 2 additional ones we're holding space for are, the risk of recidivism and the very, very formal standardized instruments that assist with assessing that. And then the child or loved one of incarcerated individual, like family member incarcerated, parent incarcerated, or loved one incarcerated. That is a critical concept in ACEs screening as well. We have identified some things as being out of scope, but this is currently where certainly the primary concepts of incarcerated and its subtypes and community supervision and its subtypes we're holding space for and trying to scope, and then we have these other 2 as well. Anything else to note here before we go on? I wanted to have some of our SMEs help us unpack this sequential intercept model, because I think it's actually really helpful and relevant if we have time. Any other questions on this slide? Someone mentioned, Eileen, you were mentioning that we didn't have the community supervision stuff. It's right. It's here. I didn't lose it. It's incomplete. I think there's some things that we need to add as well, but this is where we're headed there. Are we good?
Sorry, I just think one thing is, I don't think treatment courts would say that they are community supervision.
We were weighing just this.
Yeah.
All on a Friday, Andrea, finger on the pulse, me, like, is it a program or is it a community? Yeah, is it a, and then we had a whole courts. Again, this is the nature of a work in progress. That one hadn't been sorted very well, and you put your finger right on the pulse. So correct. More to come tomorrow.
Sarah, if you just call it continuing supervision, to me, that would imply that the person is not yet in control of their lives.
Thank you.
That's the key here. They're not in control of their lives. They have to be reporting, or they're wearing ankle bracelets, or who knows. I don't know all the details, but they're not in control of their lives. And so using the word community, which is normally a positive, evokes some positive thing, really doesn't seem appropriate here, even if the people in criminal justice use that term. It's a euphemism. It's trying to cover that they are continuing to control how this person can live. So continuing supervision expresses that they are still being supervised.
We are bound to the way things are named and can cite references for. That is this is the grounding of we have to defend everything. But I hear what you're saying. Smeeze, any thoughts on that? We do have to point to the customary way of naming things, usually, unless there's a reference that says it differently.
So this is a language access problem. We are trying to do justice to something which traditionally and conventionally no justice is involved. It's retribution or or whoever. So I wanted to build on what I think Andrea Findley just said. This isn't community. This is
Smeeze,
right.
there might be alternate terms we can use, and thank you so much for naming that. Tyler, it looks like you were going to say something.
I was just going to say that there may be a like parent concept around courts, because there's going to be like active legal proceedings, there's going to be treatment courts, and so there may be sort of a additional parent concept that could sort of identify something other than community supervision, but that identifies someone as sort of having at least some level of oversight or legal involvement without being incarcerated or formally on community supervision.
Yeah, sorry, I agree. Legal supervision type of a thing.
Sounds good. And I think the sequential intercept model does a pretty good job of showing from a mental behavioral health perspective how these concepts relate in levels. Are we good on this slide? And we can go, anything else to say on this concept? Julio, hi.
I think this relates to what I was saying earlier on language access and prevention versus mitigation, and personal agency, right? We're gonna need to, I mean, to your point, we're gonna need to use the language that we currently have, and we can't make up things that are not sort of accepted in the canon. Okay, fine. Or in the system, fine. But we can at least, in this process, identify those gray zones that need, right, further development. And perhaps that can also, from a concept standpoint, lead to creating like an advocacy agenda in terms of how the language needs to change over time, right?
100%. 100%. And I think the truth is that if it's an emerging standard, we can point to that too, right? Like a lot of like our definitions in the justice world are not, they're, you know, people with lived experience or community experts or nonprofit definitions, right? So we're not bound only to the way certain entities or the entities that have been in power have named things for a very long time. If through every domain we've leaned into alternative definitions, alternative naming, you know, data justice, you know, or we do this as on a regular basis. So happy to lean into that space as well. And Lucy, thank you for bringing that to light. Any other thoughts?
So again, I can save this for tomorrow, but I just wonder, I'm thinking about what you said, Tyler, of the courts. And so somebody in a specialty court is, you know, mostly under supervision to some degree, although there are people who aren't, who don't have any, and they have chosen to be in the court. And if they quit, nothing really would happen, except they might have to, you know, pay a bunch of fines and other things. But other courts, people aren't under control, or it's not this like long time period. So this is where I'm like, is incarceration really the parent concept, or is it legal involvement? Like, is it, I guess I'm just, it's so fluid. I mean, that's one thing about the sequential intercept model, right? Is like people move through the different parts of it, you know, often many times in a single involvement.
That's a good thing to think about. There's some legal involvement that we agree is out of scope, right? Because like we didn't want civil legal involvement to be in scope for this work. That was too big and too different, right? You know, so but that's a good thing to bring back tomorrow to try to figure out how that works. If we go to we keep on talking about the sequential intercept model, maybe we can I think it's the next slide. I think. Just yes. So what we so we were just talking about this, so I thought it might be wise just to bring it. So this actually, I think it's pretty interesting. If somebody, any one of our, so Andrea, do you want to speak to it? You talked about it on the call. Rada and Milan brought it up early in our SME recruitment this summer. Anyone want to speak to the model for our friends, like the why of it?
I mean, other people might know better, but as I understand it, it was introduced as and then I don't think intercepts 0 or 1 were in the original model, and maybe not 2 either, but it's a model trying to depict different places where interventions can occur to help people with mental health or substance use disorders and get them to kind of the right treatments. But and it's been expanded over time, and there's also population specific models. So there's one for veterans, for example, that's aligned with the resources that are available to veterans who qualify for those resources. I don't know that other people have things to say. I mean, the community corrections, I'll have to look back and see if there was a different term for that, but that is a term I've heard for a really long time for the Intercept 5 for the probation or parole piece of things. But I'd be curious if ever there was another term.
I appreciate the model because as a layperson, it starts to help me understand the flow of things, right? We have all of those concepts on our previous table, right? This is like a path of the flow of a person and how we can help them. And so it starts to make more sense to me. Big fan of models in general. Darcy. And a fan of this one. Anyone else want to say anything?
I see you, Sarah. It's all good.
The one thing I don't like about this, or that I think is a little inaccurate, is the Intercept 4. To me, it says jail reentry and prison reentry, but actually there's lots of programming in jails and prisons that happen. And there's program that happens at the both before someone's been sentenced, but also afterward in jail. So and it depends who's eligible for what also depends on where they are in that process. So I do think there's more in the incarcerated space that doesn't get represented always in versions of the sequential intercept model. There are other versions where people have laid that out a little bit more.
It makes a lot of sense. That kind of goes to what Julio was saying as well. Care within, right? At least that's what I hear you speaking of.
Yeah, exactly.
None of this will be what I'm going to say is a surprise to anyone, but I think just to keep on our radar that like the vast majority of people, particularly who go through prison, it's not like typically a one and done cycle, and that unfortunately this often repeats itself. So sometimes when you look at this, it's like, oh, you like enter and then you like go through and then it's all over. That typically, unfortunately, is like not the norm. And like if for like just as an example, when folks come to our county jail, it's not uncommon to have holds in other county jails. So you will go to one county jail, you will make the rounds to several other county jails before you come back to our county jail. So within each of these, there's like there's a lot of complexity, and I think this helps to start lay out all these different steps. But it can get a lot more complex that I don't think needs to be necessarily reflected in the codes. But someone could be currently incarcerated but have been in 5 different jails over the last month, or someone could be currently incarcerated and have just been in one jail.
Okay, just reflecting on that one. Okay, we had 5:25. So what we covered today, next slide, I think, just reflecting, and I have all these pins in my head. But Molly, we didn't get to the value sets yet. I'm so
Okay, Sarah. Next time we can, whenever we get. This is more
I know.
interesting, yeah.
Someday we'll get to value
Yes.
sets. So I want to get to this. So yeah, this was such an important conversation. So we dealt with concepts today, scoping. Our job next time is we're going to take these concepts to, if we can just stay on the all domain revisions, I just want to show people them for 5 seconds. We're going to take the pins that we held with all of our SMEs, and please SMEs help me be accountable to them so I do not forget them tomorrow. We're going to bring them, and then we're also going to review some of those concepts aligned with instruments so we can move some instruments to the master and start showing them to you in 2 weeks. I wanted to just, for the point of due diligence, because it is something that you're going to have to review, show you this next slide, because it's going to be something that's going to be included in every single slide until we vote. Next slide. I have a very loud cat somewhere in my house. So one of the things that we do when we, build our value sets and, think about implementation is we think about concepts that are in the ecosystem that we don't have in our own value sets yet. So Gravity has this meta value set, which is like it applies to every single domain. And these are some concepts that seem to align with that. So we have refer to social worker. We don't have referral to clinical social worker. We have refer to care coordinator, but not care manager, but not care management service. And so we thought those might be appropriate. Social services, we could talk about. It's what we call in Gravity a fluffy bucket. There's just a lot of stuff under there. It's big old vague. We haven't included it yet, but we want to just let you know it's there. And then discharge planning and health plan case management. So we're going to be talking about these over the course of our time, whether or not we should include them in our value sets. Rosie, hi.
Especially the clinical social worker.
Yeah.
My granddaughter has been working with people that are coming back into the community from incarceration as a social worker. She works with them not only to make sure that for their mental health and status, but also for their physical health, and they she does a lot of work with them to make sure that they they're well adjusted and are able to function, you know, and she worked for a private agency and now she's working for a health system.
Wonderful.
Yeah, but so I think that that's she really loves her work because she feels like it's making a difference. But I also think that it's a very important piece to this.
It is, and I know we have social worker, but the fact that we don't have clinical social worker just seems like a silly thing. So Rosie, we're happy to lean into that. So
And then the other thing is that, I used to run a daycare or own a daycare in the middle of what they would call prison central here in Wisconsin. They had in this community has within a half hour a woman's prison, mental health prison, a long-term prison. I mean, a very serious prison, a federal prison, and it was interesting because my daycare was like, and their social service came into effect because social service knew I would work with them to provide daycare for the families that came to live in that community, so they would be close to the person who was in prison. So there's the whole family piece that goes with this.
yes, and that's actually one of our programs we have is a federal program. So thank you so much, Rosie. You're always so good at adding these critical whys and good stories. Just a note, in our general interventions, we do have many of the concepts Dr. Springer-Sander was noting. We built a concept for community health worker that didn't exist. We have an existing peer support person, but not a specific peer support person for those who've been incarcerated. And we recognize that might be necessary as well. So these were just gaps that we, not that they forgot, they actually didn't probably even exist when we started our work. And so we just want to make sure we're being thorough. And we have social worker already as well. All right, so now if we just go to our homework, we can skip ahead, skip over value sets. Thank you all for coming. Those of you who have dropped off immediately. Anyone, so I've mentioned the SMEs hold me accountable. You all please hold me accountable too. If there's a concept you raised that you thought was missing, send us an email. This is that time where you as members can write in an email and say, gravityproject@hl7.org. I raised this as something and I feel like it's missing and I want to include it in the set, right? So that's how we submit. You can always catch up. You can listen to the recording. Again, submit any concept you feel like is important, something you feel like is missing. I mean, even Sandra could have submitted the peer support and the social worker and the community health worker concepts. They are already in there, but we hear you. And then we'll come back in 2 weeks and we'll be talking about instruments and keep on carrying on our conversation for language access and incarceration status. Thank you for a really wonderful call. This is like, it's such important work, and we're really grateful for the intersection of our subject matter experts who are talking across each of their domains as well. And I'll see you SMEs tomorrow, and have a good weekend. See you soon. Bye, sweet Rosie.
Thank you. Have a good day.